really happy to be presenting on PRT to everybody. I am now a postdoctoral associate at Weill Cornell, and I'm soon going to be starting as an assistant professor at University of Colorado. I'm a consultant with the Pain Reprocessing Therapy Center, as Daniela just said, helping lead the trainings and helping these other organizations with their chronic pain care as well. So chronic pain is a leading cause of disability and burden. Back pain is the #1 cause, and other chronic pain conditions are well represented in slots 3 and 4 as top causes of disability. Estimates are that 50 million adults in the US suffer from chronic pain. We are spending huge amounts of money in treating chronic pain and in costs due to chronic pain. 600 billion, give or take, is actually a bit of a dated figure, so I'm sure it's higher, and it's more than heart disease and cancer combined. At the same time, the prevalence of chronic pain is just increasing over time. We see this across the age range, so it's not driven by an aging population. Pain is going up across older adults. Pain is going up in adolescents as well. And when we look at this picture, where we are throwing huge amounts at chronic pain, and the problem is just getting worse and worse, I think we would all agree that we have a problem on our hands, that something is not working in the system of how we approach chronic pain. We hear this in our patients' words as well. I've tried everything. My pain started at age 12, now I'm 60. I've seen 95 different doctors. They think I'm making it up. So what's going on here? Why is this pain problem getting worse and worse the more we're throwing at it? And I will submit to you that a central problem here in our paradigm is that there is a hyper focus on peripheral structures as the causes of pain. When we know that these peripheral findings are only weakly related to pain. So for example, 87% of pain-free necks have bulging discs. 72% of pain-free shoulders have superior labral tears. 69% of pain-free hips have labral tears, and so on. So while these sorts of findings can be causes of pain, they are often not. They're often incidental findings, highly prevalent in pain-free populations. And when we look at treatments that target the periphery, we get a similar view. Here's a meta-analysis of treatments comparing real to sham surgery. So for people who haven't heard this concept before of a sham surgery, in these studies, patients enrolled and told 50% chance to get the real treatment, 50% chance you're going to get a sham. And in these cases, if there's general anesthesia, that's done, and then just a superficial cut is made, it's sewn right back up, and nothing happens. And the patient never knew whether they got the real or the sham surgery. And what we see when we look at pain is that there is a very little difference. This is not statistically significant. There's no significant difference between real and sham surgery for pain. So here, higher is better, higher treatment response. Real surgeries do a bit better, but really it's quite of a marginal benefit at best. And so we know that these peripheral treatments, treatments that target the peripheral tissue aren't working that well, and that these imaging studies of the peripheral tissue aren't revealing that much that's helpful as well. In parallel, chronic pain is associated with a host of changes across the nervous system, from the periphery through the spinal processing of pain signals up to the brain. And I am showing here just an overview of some of the many findings stemming from both rodent neuroscience studies of chronic pain and human neuroimaging findings that show there's heightened responses in the brain to aversive stimuli with chronic pain. There's a reduced prefrontal inhibition of pain, increased connectivity across multiple brain networks, including the default mode network, somatosensory networks, others. Changes in thalamic processing of pain, reduced dopamine signal, neuroinflammation, and more. And if there's one takeaway from this busy slide, it's that chronic pain is complex. It is not that the chain, pain is processed in a distributed system across multiple brain regions, and with chronic pain, we see changes in multiple locations. And these changes in the brain can cause pain to persist after injuries have healed. This work has forced us to reconsider how we think about pain, what pain is. In the old traditional view, pain was a direct readout of tissue damage. So the amount of pain you're in directly reflects how injured your body is. We now know that's not true. And one of my favorite ways for thinking about pain is as a learning signal for guiding behavior. So as an organism or a person is navigating through the world, we are all looking for rewards and looking to avoid threats. And for this and pain is a threat detection system. And for this to work well and to keep us alive, it has to be predictive. Right? If we were always only reacting to threats, reacting to the lion, we would be quickly dead. So we have to predict where the threats are. And prediction is a difficult task. We all know no one can, who can say what tomorrow will hold. And sometimes the system can go awry. This pain prediction system can go awry. These predictions have been formalized in Bayesian mathematical models. The big picture idea being that the brain has an internal model of how much pain it's expecting. That's shown here in yellow. The brain receives input from the body, some signals, and then the experience of pain is an integration of both what's expected and what is received from the body. This fits into really a bigger picture view of these active inference and generative models where that describe our sensory processing systems beyond pain and especially in pain as well. But our brain is basically playing detective. Our brain's trying to figure out what's really happening in the world, what's really happening in our bodies. But the problem is that this detective has pretty limited information. So it just has some signals coming up from the body. And based on those signals, the brain's trying to figure out, well, what's actually happening there? But it doesn't really know. It's just doing its, making its best guess. And sometimes this internal model of what's happening in the body says, injury, danger, threat, when actually that could be inaccurate. And the brain is kind of taking the evidence from the body and making it fit this view of injury. When these predictions about pain and these beliefs in injury and threat become too strong, they can become resistant to change, and it can drive these cycles, this kind of pain, fear, avoidance cycles. At the center of this model is how threatening we think the pain is. So when we think the pain is highly threatening, that's going to drive priority to pain control, fear, avoidance, depression, anxiety, and it's all going to cycle. Whereas when pain is understood to be low threat, then that we can escape from this loop. Super important to pause here on this very important point that not all chronic pain is alike. The ICD-11 very recently released distinguishes between primary and secondary chronic pain. Secondary pain is pain that's secondary to some injury or disease process in the body. In primary pain, the pain itself is the primary problem. It's not secondary to anything else. The pain is the problem. Another common framework is distinguishing between nociplastic, nociceptive, and neuropathic pain. For our purposes, nociplastic and primary are basically functionally equivalent. These also go by many other terms. We sometimes like to use the term neuroplastic pain, functional pain, non-specific pain. Sometimes people call it TMS, a whole bunch of names here. And although these are categorical descriptions, it really is a spectrum. And one kind of way to think about this spectrum, at least the simplification, is that the pain contributors to pain can be driven from the periphery, like injury in the body, or to changes in the central nervous system. And critically, a person soon after an injury could have pain that's primarily driven by the injury. And then over time, the brain can learn the pain. And now the factors that are causing the pain to persist are in the brain and in the mind. And so an animating question in our research has been, when these pain and other related symptoms are driven by these functional changes in predictive and meaning-making processes, could they be resolved by psychological treatment? Can you shift the brain's internal model? Can you change the predictions? Can you convince the brain that the body is healthy? And would that lead to the full resolution of pain? By resolve, I mean pain is mostly or entirely gone. And could this happen with a psychological treatment? And when we look at current psychological treatments, they really aren't even going for this. So for example, here's a meta-analysis of CBT, arguably the most studied, most available treatment for chronic pain. It's 3,000 patients, over 59 clinical trials. Effects on pain intensity are very small. We're talking here, for people that know about effect size, this is about 0.2. For everyone else, most of us, this is about zero, less than like half a point on a 10-point pain scale is what you get from CBT when we're talking about pain intensity. So effects of CBT are very small. And then we might wonder, why? Given everything we have been presenting on, why do these leading treatments have such small effects on pain intensity? I want to take a closer look at one of them to try to get a sense of this. So here's one workbook that is excellent for, in my opinion, for secondary pain. And the message here is pain is usually an important message from the body, alerting the brain that something is wrong and needs attention. This book will target the suffering caused by your pain, not the pain itself. So we see two things I want to emphasize here. One, premise of this treatment, something's wrong with the body, okay? Two, we're not even going after the pain. We're gonna try to help people live more, live better, higher quality of life, target the suffering around the pain. In Buddhist terms, the second arrow. All these things around to help people function better, but they're not actually going after the pain. So perhaps it's little wonder that there are small effects on pain intensity. And the reason they're not going after the pain is because the premise is that the pain is a relatively faithful indicator, more or less, that there is something happening in the body. But leveraging these insights and how pain and affect are constructed by the brain, can we do better? And this has been the launching point for all of our work on pain reprocessing therapy, which I'm going to describe now, and then show you results from our first clinical trial of PRT. So the first step in PRT is a neuroplastic pain assessment. Primary pain, nociplastic pain, those are all fine terms. Figuring out, PRT is most appropriate for people with neuroplastic pain. It may also be helpful for people who have mixed primary secondary pain, although it's not really the focus as much as neuroplastic pain. I'm going to talk more about how this assessment is done on the next slide, but just to give an example, when a patient reports that pain is moving around their body, like, yeah, the pain, sometimes it's my lower back, sometimes it's my upper back, and then sometimes it's in my hip. That kind of pattern of the spatial variability in pain is more consistent with the brain playing a major role than with there being multiple injuries or injuries that move or something like that. Now, provided someone has we have strong evidence that there's neuroplastic pain, then we can continue to PRT. And the essence of PRT is shifting from danger to safety, and that happens in several different ways. So one of the key elements is reattributing the causes of pain. By reattributing, I mean patients' beliefs about the causes of the sensations. And here we're seeking to help people reattribute it, to understand that the pain is actually due to non-dangerous, reversible mind or brain processes. Those are what's driving the pain. And when we do this with personalized evidence building, so we would tell the person, hey, your pain's moving around your body. That's one of the indicators that we know that we have that your brain's playing a major role here. And that kind of evidence building can help a patient understand, like, oh, right, this is what's happening for me. This is what's happening with my pain. Another, a major component here is reducing fear of the pain. And there are many techniques in PRT for reducing fear of pain. One of the key techniques is somatic tracking. I've got a great demo of this on a following slide. So I will just say on this slide that this is a way of paying attention to the sensations, a form of an interoceptive exposure, where we are using mindfulness to help people stay present with the sensations, safety reappraisal, start to think differently about the sensations, and this positive affect induction, which is a way of lightening the mood, using some jokes, telling some silly stories to help people learn that the pain is safe. Approach behaviors is another really important piece here, helping people re-engage with the thing they've been avoiding. If they stop playing tennis, start playing tennis. I was just thinking this morning about, a former patient who had head pain, and this patient was so precious about their head, they would not let their head move at all. So part of PRT is, you start head banging and things like that. You gotta help people start to do these activities. And there's a particular process in PRT for how to go about that. And this fourth piece of addressing non-pain threats. This is things like stress, self-criticism, unrelenting standards that we hold ourselves to. Now, living in a continual fight or flight mode. The view in the understanding in PRT is that the brain circuits that process pain and process other threats have some overlap, have some intersections, such that non-pain threats can ramp up the pain. And of course, so many patients are very aware of this connection as well. Okay, so how is this assessment done? Step one is ruling out clear medical causes of pain. And step two is these positive indicators. So I mentioned earlier the spatial variability, or a spatial spread or variability of symptoms that are inconsistent. So my back hurts when I'm sitting in a car, but not when I'm sitting in a chair. Kind of hard to explain from a biomechanical perspective. When people are exhibiting high levels of fear and avoidance, that's a positive indicator. When there's a history of multiple pain or sensory processing conditions, sensitivity to bright light, sensitivity to sound, stomach aches, headaches, back pain, knee pain. When there's a history of childhood adverse events, when we see co-occurring symptoms like fatigue or depression. So none of these alone is definitive, but when we see more and more of these, our confidence as clinicians it's increased that the mind and the brain are playing a really important role in this person's symptoms. And here's a demo of somatic tracking. Let me just turn up my volume. And this is from a live training. This is a patient with neck pain. And you'll see Alan Gordon doing somatic tracking with him.
So Felicia, I just want you to turn your head 20 degrees, 0, 20 degrees, and feel the pain. Let the pain come. But it doesn't matter if the pain comes, because we know that there's nothing wrong with your neck. We don't care about stamping the pain out. All we care about is reframing your understanding of what's actually happening. Your neck is sending the sensations to your brain, and your brain is going, ah, and that's all that the pain is. But this pain is safe. As you keep going like that with your neck, it's just a nice, gentle stretch.
So we see here a number of these elements of, reappraising the pain as non-dangerous. This is just a nice, gentle stretch. This is just how your brain is processing these sensations. There's this mindfulness component of the patient paying attention to the sensations with less judgment and more acceptance. And then some sense of humor, helps lighten the mood, which makes it easier for people to relate to the sensations as not dangerous, as not threatening, kind of cuts the tension, lightens the mood, easier to have that relationship with a sensation that's been so terrifying and debilitating. So I am going to tell you now about the first randomized controlled trial of PRT. This was 151 chronic back pain patients recruited from the community. Back pain was at least 4 out of 10. Here we targeted primary neuroplastic CBP, chronic back pain. So we excluded people with leg pain worse than back pain. It's not because they necessarily have radiculopathy, but because the diagnosis can be more tricky. For similar reasons, people with a history of metastasizing cancers, because there could be a chance that the pain is more due to that, and the diagnosis could be more involved. And what we really wanted to target to enroll in this study was people with primary chronic pain. Oops, there we go. And let me emphasize that all spinal conditions were welcome here. So if people had bulging discs, scoliosis, stenosis, welcome, welcome, welcome. Those were not exclusion in any way. This trial was published earlier this year in JAMA Psychiatry, and it's freely available. You can download the paper and read the paper. It's not behind the paywall. So if you just Google any of this or my name, you will find that paper. And I'll be presenting data from that project, most of which is in the paper, some of which is going to be coming in getting published in upcoming papers. So patients here were about 40 years old, slightly more female than male, about 10 years of chronic back pain. And the disability in this sample was 23 out of 100. So this was, which is in the kind of, moderate and moderate range of disability, low end of the moderate range. And this was like a highly educated population just due to the recruitment from the Boulder area. So important to keep in mind, as we look at this data as well. Patients were brought in, completed functional brain imaging, a blood draw to look at inflammatory markers, a battery of patient-reported outcomes. The primary outcome in this trial was pain intensity, because in PRT, we are targeting the pain. This is not quality of life. It's not disability. It's pain. Patients were randomized to 3 groups, 3 conditions, either usual care, which is keep doing whatever you're usually doing. If it's stretching, chiropractic, ice packs, whatever. A placebo condition, patients who received a placebo injection to the back, or PRT. And in this study, it was 1 telehealth session with a physician, followed by 8 psychotherapy sessions delivered over 1 month. Patients then returned for an identical assessment session after treatment. Here's the concert diagram for those who are interested. The one thing I'll emphasize here is that retention was high. So the 45 people who started PRT, all but 1 completed treatment. So so here are the primary outcomes. Treatment wraps up here at post-treatment, and we follow patients for 1 year after. In the usual care condition, there was a reduction from 4 to about 3, and that was maintained throughout the year, a follow-up period. There was a significant placebo effect. In the moderate size, you can see it, if you can notice the interaction here. Placebo effect was not maintained through the follow-up period. And in the PRT group, we saw a large reduction in pain intensity from about a 4 to about a 1, which was largely maintained throughout the 1 year follow-up. The effect sizes here are shown here about 1.75. So if you recall, the effects of CBT were effect size of 0.2. So multiple times larger reductions in comparison to 2 points on a scale here. I'm showing here the same data in a different way. Each dot here is one patient in the study. And what we're looking at is percent change in pain. So in the usual care group, some people got worse, some people stayed the same, some people got better. In the placebo arm, the results look, a bit better. In the PRT group, no one got worse, one person stayed the same, and everybody else got better. But what really caught our eye was this cluster of patients who reported 100% reductions in symptoms. And to operationalize this, or to characterize this a little more closely, we defined the category as pain-free or nearly pain-free. This is people who are reporting 0 or 1 of 10 pain. And at post-treatment, 2/3 of people in the PRT group were pain-free or nearly so, compared to 20% or less in controls. 1 year later, half remained pain-free or nearly so in the PRT group. And I just want to put a face on this. And I'll show here clips from 2 patients who were in the study who consented to have this footage shared, describing their experience of becoming pain-free or nearly so.
I can honestly say I have 0 back pain right now. It's drastically different. I think I was 7, 8, 9, when I came in.
18 years. And it never stopped hurting for 18 years. I don't have any. I'm pain-free. It's amazing. I can't even believe I'm saying it, but it's true.
And let me emphasize that for people who are less familiar with the literature on psychological treatments for chronic pain, the status quo is basically managing pain, helping people manage better. Eliminating pain, becoming pain-free is not so much in the framework for several leading treatments. So many people here got out of pain. And our question was then, well, how? Right? Because if we understand how, then we can try to do this with our patients in other clinics and other contexts. Like, what are the mechanisms? How does this work? Now I'm going to talk about a few different ways we looked at this. And this is, let me just also emphasize that this question of how and what are the mechanisms is really important for validating our theory. Because I could stand here and talk about how I think PRT works, and these are the components that I think are important. But the way to know if they really are the important components is to look at these mechanisms like I'm going to present, so we can really try to understand if PRT works the way we hypothesize, the way we think it works. I'll be talking about some self-report measures, some natural language processing analyses, brain imaging, and also some qualitative analysis of patient interviews. So we asked people to complete this wonderful questionnaire, the Tampa Scale of Kinesiophobia, which has these great items. Pain always means I've injured my body. I wouldn't have this much pain if there wasn't something potentially dangerous going on in my body. I'm afraid I might injure myself if I exercise. My accident and problem has put my body at risk for the rest of my life. So this is a wonderful questionnaire. I would invite anyone who wants to start administering it in their clinical practice to do so, and to understand how our patients fear the pain. And these are exactly the kind of beliefs that PRT aims to change, to undo, to reverse. And what we found in this study was large reductions in these pain beliefs in the PRT group. And critically, the extent that people reported reductions in these fear beliefs correlated with their reduction in pain intensity. So here in blue is the PRT group. And the more there was a reduction in these fear beliefs, the more pain went down as well. So supporting this idea that changes in these beliefs are a mechanism, are central in PRT. We also conducted mediation analyses, and those are reported in the paper that came to the same conclusion. One of our patients kind of expressed this best. So let me give her the stage for a moment.
So the pain now, when I do get some pain, back pain, I'm more like, bring it on, come on, bring it on. No, this is nothing, you know, I'm not in any danger, I'm not afraid. If it stays, it stays. If it doesn't, great, but it doesn't intimidate me.
That's really beautiful attitude of fearlessness and right. Doesn't intimidate me. You can tell her whole affect around the pain is like, whatever. I am not afraid of it at all. So what about this idea about what people think about the causes of pain? So we asked our patients in this study to tell us in their own words, what do you think is the cause of your pain? Top 3 reasons. What are the top 3 causes of your pain as you see it? And people wrote us, little responses. And what you're seeing here is the most commonly used words pre-treatment. The bigger the font, the more common the word was used. So some people are saying stress. There's a lot of injury, sitting, scoliosis, disc, car, falling, weight, activity, posture, arthritis, surgery. Okay. And a pretty, I would say, standard kind of physical beliefs about, physical, I mean a kind of medical, below the neck sort of beliefs about back pain. After PRT, we saw a bunch of different words in the mix. Fear, thoughts, neural pathways, anxiety, feeling. So to look at this more quantitatively, we developed a natural language processing algorithm that scored these attributions for the presence of mind-brain words. And the way this worked is that a score of 0 would be people thinking completely like biomedically about the causes of their pain, and a score of 3 would be people thinking completely, attributing the pain fully to mind or brain processes. So the first thing to point out is at baseline, participants were pretty heavily skewed towards the biomedical side. We saw a large effect of PRT on these attributions, that people in the PRT group started attributing their pain much more often to these mind or brain processes. And again, critically, the extent to which a person shifted in their attribution correlated with their pain reduction in the PRT group shown in blue. So the more their kind of mind-brain attribution went up, the more their pain level went down. Supporting this idea that changes in how people think about the causes of their pain is a really important target and a really important mechanism that we want to be engaging in PRT. To get a little more of like a feel of the data here are the top words that people started saying less often. Activity, posture, and age were reported much less often as causes of pain, whereas anxiety, fear, and neural were reported much more often as causes of pain. So reattributing these causes of pain. Okay. What did the brain imaging show? Just checking the time. This is a bit of I'm going to give more of an overview, and the full details are in the published paper. But we found reduced responses in these 3 prefrontal regions to evoked back pain. So people, while they're lying in the brain scanner, we were inflating this kind of inflatable pillow under their backs that distended the back in a painful way. And what we found was that there was less of a response in these 3 prefrontal regions for PRT versus control to this back evocation. So supporting this idea that they were in less pain, there's less of a brain pain processing response as well, reduced brain activity during pain processing. The neuroanatomy here is interesting in terms of where these changes are happening, because the anterior insula, anterior mid-cingulate, and anterior prefrontal cortex, these are all parts of the prefrontal cortex that contribute to the threat appraisal across domains. So these regions are all engaged by threats more broadly and play a really important role in threat processing. So these reductions are also consistent with the idea that the brains were responding with less of a threat response to these stimulations. We also saw increases in connectivity or communication between these regions and primary somatosensory cortex. And these results are interesting, and they suggest that with more communication between, so the primary somatosensory cortex has a more direct representation of what's happening in the body, and that those regions are talking more with prefrontal regions who are making sense of those sensations and interpreting and giving meaning to those sensations. So it's consistent with this idea of a greater bottom-up influence on pain, that the brain is more in tune with what's actually happening in the body because there's more communication from primary somatosensory cortex to the front of the brain. And let me also emphasize that brain imaging results have multiple possible interpretations here. And there's certainly more work to be done on the brain mechanisms of PRT. This final piece was emerged from interviews where we asked people to tell us, in interviews, what did they think was helpful for them? What was their experience of PRT? And because this can pick up things that we don't always find in the quantitative analyses. And this is what we found, that in addition, so these results confirmed what I've been telling you so far about reattributing the causes of pain, reduced fear of pain. But people also talked a lot about these non-pain threats, about feeling safer in a more global emotional way. For example, I think I was just so overwhelmed emotionally, the coping strategies I was using, I just couldn't do it anymore. And I had to go somewhere and it went to my hip. Or someone, talking here about negative emotions, being present with the pain and also being present with my emotions, allowing myself and giving myself permission to feel and experience emotions, helping people feel safer in a more global way is another core component of PRT as well. Let me address some of the limitations of this research study as well. So there were imperfectly matched control conditions. The placebo control wasn't matched in terms of amount of clinician interaction. We're starting a study soon comparing PRT to CBT. So to address that, the patient sample here was 89% white. The clinicians were experts, and the patients were in the low to moderate disability range. Let me pause on that to say that in our data, we did not see any evidence that the extent of disability, that treatment response depended on how disabled people were. Regardless of disability, people had a similar response in our data. So in these are all raise very important questions about generalizability, which we're now addressing in future research. Though I'll say that for many of us, clinicians are also finding good success with these methods. Some of the key findings here. One is that psychological treatments can resolve a substantial portion of primary chronic back pain. We don't think this is limited. We don't think chronic back pain is special, that this could apply equally well to any primary neuroplastic pain condition, or I shouldn't say equally well, but it applies equally to any chronic neuroplastic primary pain condition, and that it is possible to resolve these conditions with psychological treatments, to resolve or nearly resolve these conditions. And some of how we think this works is by reducing fearful pain beliefs, reattributing the sensations, changes in these brain pathways, and broader changes in emotional functioning. And PRT seems to be a helpful and powerful framework for engaging these mechanisms and helping to get people out of pain. Great, that is the end of my lecture piece. Here's the link, like Daniela showed earlier, for the PRT certificate. And let me also spotlight the institute and the training program. So there is, if this seems interesting, appealing, want to learn more, want to get trained, there's a great program that Daniela and others have prepared. Here's the website. It's 21 hours over the course of a month, and people are giving really positive feedback about their training experience. Great. So I can stop here. Do we have time for a few questions, Daniela? Can I put them
Yeah, thank you so much, Yoni. I think we do have a time for a couple of questions. Let's take maybe 3 or 4 questions, and you can raise your hand.
Okay, and there's been a lot happening on the chat as well. I'm gonna look at the Q&A because people have been typing those in. Joy asked, did you use PRT and find results with autoimmune pain such as EDS or MCAS? Autoimmune pain would be in a different category in my mind than primary neuroplastic pain. That being said, the diagnosis is really important here. I think there's a lot of people who have diagnoses like EDS that if they were assessed by someone within the PRT framework, they would likely, they might get a different diagnosis of primary pain, or that's what's really driving the symptoms rather than the autoimmune process. There's a lot of discrepancies when we look at autoimmune conditions in terms of the severity of the medical condition and symptoms. Some people have a very high kind of disease process and no symptoms. Some people have very well managed autoimmune conditions, but the symptoms are still all over the place. And so I wouldn't take one of those diagnoses as definitive, in any way, though. Yeah, there's also interesting questions about neuroimmune interactions and whether, how a treatment like PRT might act on the immune system. But I don't know.
And someone asked about for CRPS. I've used PRT for CRPS. It's really any unwanted sensation. It doesn't only have to be pain. It could be something like fatigue, chronic fatigue we work with, or even with CRPS, there's swelling. So it can be for swelling or skin conditions. And the idea is when we decrease the level of fear around the symptoms, then usually the symptoms decrease as well. But we are not gonna be able to go too deeply into that today.
Anonymous attendee asked about the difference between PRT and pain neuroscience education. One thing I meant to say and I forgot, and so I'm really glad that this question gives me the chance, is that, treatments don't materialize out of nowhere, and PRT has many connections and links to many other approaches, and that's really important to recognize and acknowledge that as well. And so pain neuroscience education, like the work by Lorimer Mosley, David Butler, and others there, is definitely one of those modalities that has a lot of connections and links to PRT and has been helpful there. One of the main differences is in some of the techniques for changing, like somatic tracking and interoceptive exposures are not part of pain neuroscience education, in my view, as I understand it. I'm not sure whether this personalized evidence building step of helping people really shift these beliefs. So I think some of the goals are pretty similar, but the techniques in PRT help people really shift those beliefs from the danger in me to safety in me.
I see another question about working with people who have maybe a combination of structural issues or diseases and neuroplastic pain. Should we address that, Yoni?
Sorry, I was reading another question. Say that again.
Oh, okay. So, I'll address this question of how do you manage working with people who do have a combination of structural issues and neuroplastic pain. So, a good example of this would be if you're working with someone with maybe MS or with cancer. So first of all, it's important to note that when you're using pure pain reprocessing therapy, we want to make sure that someone is diagnosed with neuroplastic pain. But when you're working with someone with structural issues or diseases such as cancer, we can potentially lower pain symptoms because there's usually a lot of fear around the symptoms themselves. In fact, almost all neuroplastic pain has a layer of added suffering or amplification of symptoms. And in those cases, PRT tools can be used to help reduce symptoms and suffering and almost turn down that volume knob by turning down the fear. So let's go back to that example of, let's say, someone with cancer. Patients may develop pain symptoms that are true to the cancer that they're experiencing. And they may also experience an amplification of symptoms or even a development of novel symptoms due to increased levels of anxiety around sensations or conditioned responses. So in this case, you really want to work with evidence. And this is something that Yoni keeps on talking about, of what is the expected pain from whatever disease that they have versus what is not expected. And so in this case, you might want to work closely with a medical physician on this to know what is expected. And we would never want to expose a patient to something that's actually dangerous to them, because that's only going to bring on more fear. So you really want to know what your parameters are. But what you always can do, if you're not going to challenge conditioned responses, is work with fear around the symptoms. But we always want to do that in an authentic way. And again, we're not going to be able to go too deeply into the actual tools, but one idea is A, to work with a physician around your parameters, B, to work with the evidence, and C, to always, it's never harmful to help reduce the fear around the symptoms to reduce suffering. Is that clear? Or?
Yes, thanks, Daniela.
Sure.
There was a couple of questions about headache or migraine. I would say that we haven't done any studies of PRT for those conditions. In our clinical experience, it can be, very effective. Would you agree?
Mm-hmm.
Headache or migraine? Yeah.
Absolutely.
Absolutely. Emma asks, if pain is chronic but accompanied by physical symptoms of swelling, does this rule out primary neuroplastic pain? I think that's a really interesting question. I don't think I have I don't think we know. I would certainly be more hesitant to give that diagnosis if there's swelling. At the same time, mind and brain processes can drive swelling, absolutely. So there's some research showing that when people with CRPS imagine doing something scary, like if they have hand pain in the study and they're imagining opening their hands or closing their hands, then swelling increased after they imagined doing that activity.
Mm-hmm.
So it's a good question, and I'd like to know more about how the brain can create or cannot create swelling. Carrie asks about comparison to clinical hypnosis effect. I think there's definitely some overlap there into the somatic tracking technique.
Mm-hmm.
Yeah. Do you see that, Daniela?
Yeah, hold on.
With
I mean, it's funny because Paulina and I actually presented last week along with a hypnotist in terms of how does that help reduce chronic pain. And I think that it's something that can help a patient feel safer in the moment or be able to kind of let go of some of the fear. And in that case, it can help reduce symptoms. So there is some type of overlap, but I think how PRT differentiates itself is that there's a focus on the psychoeducation around there not being anything structurally wrong. So it's not mindfulness alone or hypnosis alone, but there is nothing wrong with your body. And that safety reappraisal piece of you are safe, and whatever safety means to that patient or whatever can feel authentic to that patient. But again, it's that focus on there is nothing structurally wrong with you.
Yeah. What was the length and frequency of PRT? In this study, it was 9 sessions over a month. So we're twice a week in this study, which in a small number of studies that have compared once weekly to twice weekly therapy, kind of get to the same place, but get there faster or do slightly better with twice weekly. So that could be it's like a good format. Alicia Dorn is asking about the trial demographics. We're starting another study this fall with a more diverse population. So stay tuned for that. Anonymous asked about how this compares to other somatic therapies, such as somatic experiencing. I think there are a number of important differences, as well as some overlap, but one of the main things is giving this diagnosis. It's like, this is what you have, your primary pain, it's neuroplastic pain, helping them, change their thinking around that, and then learning to pay attention to the sensations and reappraise them as safe. Whereas in somatic experiencing, it would be more, as I understand it, is more like shaking or other expression of pent up bodily energy that needs to be processed or released. In PRT, it's more reappraising as safe, allowing, letting it be there.
And I think, like I said before, it's that heavy focus on, also working with the cognitive brain and not just the primitive brain. Whereas I'm not so familiar with somatic experiencing, but am I correct, Yoni, in that it's more about the primitive brain, or speaking to that?
I don't know it well enough to say. I also don't like that term, primitive brain. So
I know. Sorry.
Let's not get into that.
I know.
Yeah.
But also, we also have two prongs to our approach, which is working with the fear around the symptoms themselves, but also working with our patients' fear in general and helping to reduce that. So it kind of also takes that a step further.
Yes, I think that's also another important difference from like pain neuroscience education that we talked about, this combination of appreciating the role of other threats, people living their life on high alert, and how that contributes to pain.
Right. How do those other threats make the symptoms kind of perpetuate?
Exactly.
Mm-hmm. Okay, well, I think we are going to stop with the questions for today, but thank you so much to everyone who joined us. And thank you so much, Yoni, for that very clear presentation. Thank you so much.
Yep. Thanks, everyone. Yes, PRT is available by telehealth, and the training is all on Zoom. So yeah.
Mm-hmm. You can find out more at painreprocessingtherapy.com if you're interested in resources or the certification training or any of that, or just learning more.
Great. Okay. Thanks, Daniela.
Bye.
Bye.